Hi everyone, my name is Sian and I'm from the London School of Hygiene and Tropical Medicine. Today I'll be sharing with you some preliminary findings from a multi-country analysis of COVID-19 handwashing determinants. This research is conducted by the WashM project, which I'll tell you a little bit more about in a moment, but it's an initiative that is developed by LSHTM, Action Contre la Faim, CAWST, and which is funded by the Bureau of Humanitarian Affairs. WashM is a process for rapidly designing more evidence-based and context-adapted handwashing programs in emergencies and outbreaks. WashM is designed to overcome some of the common limitations of hygiene programming in crises. It aims to help humanitarian actors feel that hygiene behaviour change is something that they're really capable of. It aims to allow programs to utilise evidence and theory while also being rapid and being feasible in humanitarian contexts. WashM also helps response actors to contextualise their programming and develop hygiene programs that are sensitive to the needs of vulnerable crisis-affected populations. The research we'll be presenting today is based on data extracted from users of the WashM process. So I'm going to start by telling you a bit about the process so that you understand how results were derived. The WashM process begins with response actors learning about the 5 WashM rapid assessment tools. These are qualitative and are designed to understand the determinants that are most likely to be affected by a crisis and which can be useful for program design. Once humanitarian organizations have used the rapid assessment tools to learn about behavior in their context, they enter the results into the program designer software. Data collection staff work in teams to discuss the results and then answer a set of multiple choice questions in the software. At the end of the process, the software selects a set of hygiene promotion activities from a list of 80 activities, and this is based on those which are most likely to be appropriate for the contextual circumstances. Each activity is presented a bit like a recipe with instructions for budgeting, time, what is needed, and how to do it step by step. While WashM is designed to be rapid, it's been developed through several years of research and applied testing as well. So as you can see here from the diagram on the slide and the map in the background, to date WashM has been used in approximately 100 humanitarian crises or outbreak situations by 60 different organizations. Again, to understand this data, it's also necessary to understand a little bit about how WashM responded to the COVID-19 pandemic. By complete coincidence, we had planned to launch our full software package at the beginning of March 2020. And if you scroll your minds back, you might remember that at this point in time, we thought that COVID-19 might be a relatively localized threat. Nevertheless, we decided to act with caution and adapt the software so that it could be used for COVID-19 response programming, should it be necessary. Understanding that COVID-19 was a respiratory disease, we also cautioned against the use of WashM or other in-person data collection tools in the early phases of the response. Instead, we developed guides and webinars with rapid, easy-to-do hygiene promotion activities that worked well across contexts and which could be done safely. We provided real-time advice to hundreds of organizations on hygiene programming, and eventually this led us to become a founding member of the COVID-19 Hygiene Hub. As the pandemic progressed, we noticed some organizations were in fact using WashM, and we conducted interviews with them to understand their tips for doing WashM effectively remotely or safely in person. And we shared these tips via the brief that you see on this slide and which is available on our website. So the research we're sharing here today is based on summary data that organizations have entered into the software from around the world when they've been using the rapid assessment tools. For each data set we have we've gone through a process of seeking consent from the organization and then verifying that the data is actually real. We then asked users to complete a short survey designed to understand the quality of the data collection and how the process is being used during the pandemic. We then descriptively summarized the data sets. For this initial analysis, we've included only those data sets where COVID-19 was identified as the primary disease of concern, with the aim of assessing whether there was similarity across these data sets. We plan to complement this analysis with in-depth interviews among a subsample of users with the aim of developing richer insights about the practical use of WashM during the pandemic. So as I present the findings, it's useful to just bear in mind that these patterns are being derived from multiple levels of summary and extraction. The data itself began as qualitative interviews, focus group discussions, and observations with crisis-affected people. And it's important to remember that as we summarize up, we lose some of that nuance and richness to interpret the data. The tools themselves are, of course, qualitative, and therefore the sample size is relatively small, and the population is selected purposively to represent diversity. By the time it's entered into the software, what we have is a summary of common behavioural patterns within a particular region. And so you can interpret this as what the majority of people think or do. The research is ongoing as well. And so included in what we will present today is 29 COVID-19 datasets from 9 countries. And these are conducted with 8 different organizations. We do see some clustering, as you can see from the dot points here. For example, this would be where WashM was used multiple times within one country in different regions, such as what we see with Guatemala, Somalia, and the Philippines. What we do see in this data set is also that participating populations were often affected by multiple crises at once. In 12 project sites, this included other outbreaks, but it was also common for projects to be focused on displaced populations and those affected by conflict and disaster. So WashM does also cover information on programming constraints. And so what we can see here is that WashM was often used as part of short-term COVID-19 response programs, most of which received relatively small hygiene promotion budgets. However, this data also indicates that WashM may have been used within longer-term humanitarian programs in order to adapt their work to the pandemic. One other interesting insight here was that most organizations felt that they would be able to reach populations safely throughout the course of their project, indicating perhaps that lockdowns and restrictions did not have a large impact on programming within these settings. So now we come to the findings related to behavioural determinants. The first set of insights comes from our handwashing demonstration tool, which is designed to understand the behavioural setting where handwashing takes place. That is to say that it explores whether the physical environment is designed to enable or act as a barrier to behaviour. And what we see here is a commonality across projects in relation to the absence of handwashing facilities at the household level. Most projects found that the majority of households did have soap available, but that it was often stored elsewhere in the house, making it hard to practice handwashing at key times. Similarly, the type of soap available was often things that were not intended for hand washing. For example, laundry powder, which while effective for hand washing, can cause skin irritation if people use this regularly to wash their hands. Just like soap, water was often stored elsewhere in the house and wasn't conveniently available for hand washing. Acute water scarcities were only noted as an issue in a minority of projects. Our second set of insights from the motives tool. This tool is designed to understand motives associated with hand washing and what motivates populations in general. Now, what we saw here was that populations most commonly linked hand washing across contexts with motives of status and disgust, which for those familiar with the literature is relatively consistent to research in non-crisis settings as well. We found that populations identified as being hardworking and neat and orderly, and that they aspired to be wealthy and educated. However, it does appear that there is more contextual variation in some of these opinions around motives, so that's perhaps worthy of further exploration. Our next set of insights come from the disease perception tool, which explores broader health concerns, perceptions of COVID-19 vulnerability and susceptibility, perceived efficacy of hand washing as a prevention method, and normative perceptions of behaviour. We found that in most settings, COVID-19 was listed among the population's 5 greatest health concerns at that point in time. A relatively low number of projects reported that the majority of their participants thought that they were vulnerable to getting COVID-19 in the next 6 months. We also saw that in many settings, it's still quite common for people to doubt the effectiveness of hand washing as a way of actually preventing COVID-19 transmission. Lastly, 41% of projects reported that the majority of their populations felt handwashing had increased in their community because of the pandemic. One of the rapid assessment tools, the personal history tool, is specifically designed to understand the broader ways that a crisis can affect the lives of their populations. Where possible, this tool is used with a person or people who have been directly exposed to the outbreak. This could include, for example, being a confirmed case of COVID-19 or having a family member who was a confirmed case. To be clear, this is done once a person no longer has the disease. Here we see a high number of projects reporting that the majority of their participants felt that their roles within the family or the community had been changed due to COVID-19. 40% of the projects said that a majority of their participants faced stigma due to the disease. And almost all projects reported that the majority of their participants had said their hopes and goals for the future had changed because of their experiences of COVID-19. Perhaps unsurprisingly, we saw that a majority of projects found participants commonly felt that their economic situation had become more precarious, and many reported feeling less agency because of being reliant on others for basic aspects of survival. So an example here might be that we might imagine this response relates to distributions or reliance on distributions from humanitarian or other actors during the pandemic. Given that isolation and physical distancing measures were in place in many areas, it's interesting that only 40% of projects reported that a majority of their participants felt that they had become less social during the pandemic. We also summarized the ways that WashM was used during the pandemic. So this, of course, only relates to these specific 29 data sets and does not necessarily reflect other learning about how WashM has been adapted during the pandemic. But generally, we found that the training and data collection was being conducted within what we would kind of expect of the WashM implementation in terms of timeframes and also in terms of following the recommended processes. For example, on average, organizations trained 9 staff members on WashM, and pleasingly, there were several examples of staff coming together from different organizations to do training and data collection together. And from previous experience, we found that this can often promote shared learning and project alignment. Almost half of the organizations trained staff within 1 day. However, we did see some organizations running shorter sessions that were spread out over the course of a week. The need for some staff to join remotely and work pressure associated with the pandemic may be possible reasons for this, this staged training that we tended to see. Organizations did typically use all of the rapid assessment tools, and interestingly, in almost all cases, these were conducted in person. As I mentioned, we do have some qualitative learnings about remote WashM data collection, but it appears this tended to happen in a minority of settings. And 31% of organizations completed the data collection in just 1 day, while again, we see some organizations spacing data collection out over time, sometimes up to 12 days. 85% of users had begun utilizing the WashM recommendations, but some reported having to adapt these quite a lot. We are hoping that through our qualitative interviews, these can help us understand more about how organizations are adapting and utilizing those WashM recommended activities. At WashM, we recognize that our process is still imperfect, but we really value all of our users who are willing to share their experiences so that we continue to strengthen the process. Over the coming 1.5 years, we'll be continuing to do multicultural analyses of these data sets, including specific sub-analyses by geographic region and different types of crises. As mentioned, this will be complemented by interviews with users, as well as broader process evaluations of the WashM approach. We're going to be using all of these insights to improve the software, develop synchronous and asynchronous trainings, and to support a community of practice and a set of WashM champions to make the process more sustainable into the future. If you're interested in learning more about WashM, please go to our website or drop us an email. We're happy to support. I'd also like to specifically thank Astrid, Hasund, Thorseth, who helped prepare a lot of the data in today's presentation. Thank you.